Good afternoon, good evening. I'm Dr. Tino Mercado, a periodontist from Western Sydney, Australia. I will be presenting about our randomized clinical study on the osteogenic potential of enamel matrix derivative when combined with xenograft in maxillary anterior ridge preservation. Cosmetic implant failures are one of the most challenging clinical tasks that we can encounter in implant dentistry. And a significant percentage of the cause of the problem is the lack of consideration in the ridge dimensional changes that happens after tooth extraction, as demonstrated by the series of studies by Araujo et al. With this, the aim of the study is one, to assess the ridge dimensional changes of the test group, bio-oss collagen with enamel matrix derivative, versus the control group, bio-oss collagen alone, 4 months after ridge preservation. We would also like to assess the osteogenic potential of enamel matrix derivative by a refined core biopsy harvested prior to implant placement. For the methodology, briefly, the patients were randomly assigned to test or control groups. The tooth was extracted automatically and the material densely packed into the socket. Free gingival graft was harvested to close the socket and temporization provided. Dental implants were placed 4 months after ridge preservation procedures and restored accordingly. Ridge dimensions were measured using specific anatomical points using CBCT taken before extraction and 4 months after extraction. A 2 by 11 millimeter refine was used to harvest a core biopsy of the ridge during implant placement. This was analyzed histomorphometrically. Let's have a look at the results. There were 42 patients, 21 in each group, and more than half of the teeth were central incisors. For the results in terms of ridge dimension according to treatment method, that is test versus control, the numbers were as follows. A visual summary: there were no significant differences in the ridge dimension between test and control groups that were observed 4 months after ridge preservations, meaning the enamel matrix derivative did not help prevent the degree of shrinkage 4 months after ridge preservation procedures. The overall ridge dimensional changes is still smaller though when compared to historical negative controls. This is when the socket was left to heal without any ridge preservation procedure, suggesting the effectiveness of this closed socket technique in minimizing ridge dimensional changes. For the numbers in terms of buccal width, these were the table. For the visual summary, when the patient's CBCT measurements were reanalyzed according to buccal wall thickness instead of the treatment performed, it was noted that patient with buccal wall greater than or equal to 1 millimeters had significantly less dimensional ridge changes, regardless of the treatment performed, suggesting the importance of knowing the buccal wall thickness prior to extraction. Histological analysis showed significantly more new bone and less residual graft in test group when compared to control group. This suggests the advantage of using biologically active materials such as enamel matrix derivative as an adjunct to osteoconductive materials such as the xenograft using this study in ridge preservation procedures. So in summary, to the best of our knowledge, this is the first clinical study that demonstrated the osteogenic potential of enamel matrix derivative in fresh extraction socket. That the test group where new bone was noted 4 months after extraction may translate to earlier implant placement, enhanced implant osseointegration, and possibly improve long-term implant outcomes. These assumptions need to be evaluated further in large multi-center study. This is also one of the few studies that highlights the important role of buccal wall thickness on the degree of ridge reduction after extraction. Thank you very much for your time.